Senator Nielsen, then we'll come back to Senator Lara.
Yes, and I too appreciate Senator Lara's decision. I understand his passion on this issue. And I think something can be accomplished here. I will point out that we are all sympathetic to immigration. It's what's made America great, the great melting pot. But it is a great country because people came here to be Americans, to become naturalized citizens, to stay here and work. And the concern I have about California now getting out ahead of the federal government is, in fact, that the federal government seems to have taken down all restraints on our borders. And we're welcoming almost anyone. And anyone who crosses the border becomes a part of an entitlement. That can be an enormous problem, particularly for the state of California. We have got to be mindful of that. And if we're even going to deal with the children, there's got to be some consideration of qualification, that they at least be enrolled in school, that we get to have civic opportunities to understand what naturalization is about, so that they then aspire to become citizens, and that there's be some kind of a cap on it so we don't get way out ahead of the federal government. I'm very concerned about that because of the potentialities facing us ahead with those borders continuing to be so open. Thank you, Senator. Senator Lara, did you have a last comment?
Yes. You know, when it is true, the fact about the indigent care and the clinics, but that is literally a patchwork, and it depends on county to county. I know Fresno County was at one point deliberating eliminating their entire care. And so, again, that is a huge population of folks that would be in peril there. And so, and if you ever visited one of these clinics, it's, again, limited scope care, which ends up costing us a lot more money when these clinics can no longer care for these people and end up in the emergency room. So, again, costing us triple the amount. Not only are we paying in the clinic side, but now we're paying at the emergency room. So we're kind of double paying for a lot of these ailments that could be treated if the person just had access to comprehensive health care and had access to a doctor. So again, I think we're splitting hairs, but I think the important thing, as we know, is to provide comprehensive health care. Whether we like it or not, these folks are here and they're contributing to our economy, and we need to do a better job to keep them healthy. So with that, I just,
Thank you, Senator. Well stated.
Ask one quick question. You gave us some numbers. It was a wide range. You said between 20 and 150 million. That's the range?
For children.
For children, yeah. I mean, that huge a range, because I was curious as how we landed on 40. That's it. I mean, normally people say it's between 50, 60, 60, 70, not between 20 and 150. So that's what I was trying to figure out. Such a huge range. I mean, it almost seems like something that I would do in terms of analysis. So that's why I'm trying to figure, and I'm not a statistician, so I'm trying to figure out how we end up with this huge range.
Sure.
Yeah.
So that is our rough estimate, and it depends on a number of factors and a number of assumptions we have to make. The biggest factor contributing to the range is how many children will ultimately be enrolled. You heard our range is between 195,000 and 240,000 children who would be enrolled. We also have to make a number of other assumptions about how the program would be implemented by the department, and so we provide the range to try to cover our uncertainty around those factors. And
we believe 40 million is sufficient. That's what I was, for this.
We find that it's a reasonable amount for 2015-16 because it's within our range of full year, fully phased in costs. In 2015-16, the program would not be fully phased in. You would have some ramp up of enrollment across the year.
And so, but in the end, the program would be representative of how much? I mean, if we're ramping it up, and I understand the phase-in process because everything is not operating and what have you, but is there a vision for the full program?
When fully phased in, that's our estimate of 20 million, general fund to 150 million.
So the 150 would be the full ramp up in the end?
The maximum amount could be as low as 20 million.
Okay.
Now you're confusing me. So you're not suggesting that with full implementation of 240,000 children, it could cost as little as 20 million?
That would be if 195,000 children enrolled. We're estimating the cost would be, on our lower bound is 20 million.
Okay. Very good.
And we'll work on an estimate based on the new amendments and get back to you on that.
Very good. To be continued. Yes. Assemblywoman Melendez.
Thank you, Mr. Chairman. Can I just ask, because that is a pretty broad range, so would it be safe to assume that that number, that maximum number that you suggested, the 150, that could be even more as we go on, depending on, you know, the services that are being provided or chosen, the options that are provided? Is it safe to assume that it could go higher than that at, you know, few years down the road?
Based on the best information that we have available to us currently, the 150 million general fund is our maximum estimate of a full year, fully phased in program for children.
Based on the number of children you know of today?
That's correct.
So assuming no increase in the number of children?
That's correct.
Thank you.
I think we also have some concerns with the population numbers that the LAO are using. So, I mean, there's a lot of variables here, and so we just need to make sure we have
We have some scrubbing of numbers to do, and we will do that. Senator Nielsen?
Just an inquiry of the ledge analyst, and maybe they can work on it, but the cost, without the offset, accounting for the offsets, what would be the cost? If you don't have that off the top of your head, but work on it for us.
In terms of offsets, do you mean the amount that we're already paying for restricted scope services and the federal funds that we will receive?
Yes.
Yes, our estimate does account for both of those.
Okay. The total cost? That would be...
What I'm providing is total general fund. That takes into account the fact that we'll receive some federal funds for the restricted scope portion of the full scope services, and also that we're currently paying some general fund for those restricted scope services. So this is on net above that.
And what is the current figure that we would be offsetting? You know that?
The amount that we're currently paying for restricted scope services for children in terms of general fund, we estimate that that's somewhere around 120 million to 180 million for emergency services just for children.
So if I follow Ms. Bothworth, then if we do this add-on, then that's all on top of this. It's an increment of what we're already doing, correct?
That's correct.
Okay.
All right, we are leaving that open.
Yeah, we'll leave that open. I just want to say that the Assembly is not necessarily opposed to the proposal. It's just that, and oftentimes in our perception, the numbers were much higher in terms of, because we did not know about the limited scope of this proposal. Our numbers were basically, you know, and like the finance in terms of $1 billion. And so we realized that that would blow the budget, any effort that we'd have to do anything else. And so we'll look at this as we look at all the revenues in this area. Okay? Thank you.
Thank you, Ms. DG. Page 5 deals with the impact of the AB 97 cuts to Medi-Cal provider reimbursement rates, a variety of different approaches. Please.
Thank you, Mr. Chair.
Walk us through this.
Sure. So the Senate eliminated the Medi-Cal AB 97 reductions for dental providers effective July 1st of 2015 for a cost of $30 million general fund annually. And Senate also provided one-time funding to exempt 1/2 of the retroactive clawback for distinct partners and facilities, including the clawback related to both the reduction and the rate freeze from previous implementation for an estimated cost of $6.9 million general fund. Again, that's one time. The Assembly eliminated the ongoing and retroactive recoupment of AB 97 and the reductions under a staggered proposal. 5% of the original 10% would be restored April 1st, 2016, and the remaining 5% on April 1st, 2017. The agenda notes that the Assembly did not forgive the retroactive recoupment for the rate freezes related to the distinct partners and facilities. The budget year costs for the Assembly action are estimated to be $25.4 million general fund, and the full year implementation would be $233 million general fund.
Thank you, sir. Ms. Bosler?
Yes, just one thing that I will note is that there has been a significant shift over the last several years in the Medi-Cal program to shift additional covered lives into managed care. Managed care rates are set annually. They are based on actuarial studies, which means that they have to be adjusted upwards if it's found that there needs to be access to additional coverage within the health plan's network. Every year in the last several years, there has been an increase in the managed care rates. That means that the providers and the health care plans, working that out between them, they figure out, how to share those increased payments. So that's nearly 80% of our lives are in managed care. So the fee-for-service rates, which is really what a lot of what we talk about here, are really for a very limited number of individuals who are not in managed care currently. And I will note that over the last few years, there have been several things that have been done by the legislature and the administration to restore some of the cuts that were made during the recession. In last year's budget, there was a forgiveness of the retroactive recruitment of many of the providers, including physicians in clinics, some of the larger providers. There was also a delay in the recruitment schedules for all of the other remaining providers by 3.5 years, which meant that the additional reductions were spread over more years. And then just in this May revise, there's an additional delay in recruitment for pharmacy and durable medical equipment. So the Department of Healthcare Services and the administration continues to monitor access issues. Also, there has been considerable forgiveness and exemption on targeted basis where there is an access issue. And just to give you a little bit of an example, that when the AB 97 reduction was put in place in 2011, there was an assumption that it would save about $676 million. Today, the AB 97 reductions are estimated to result in only $215 million. So there has been considerable restoration. At the same time, there's significantly more lives in Medi-Cal as well. So this is not a restoration that we think the state can absorb on the general fund over the next several years, and so we do not support either of the restorations.
Right. Thank you, Ms. Bosler. So Senate took its action for, among many reasons, the 2014 state auditor audit on the Medi-Cal program itself. And right as the Senate subcommittee was taking its action a week or so ago, I believe my office is probably not alone in receiving a letter from Western Dental saying that they were not going to be taking any additional patients. Do you want to comment on that, please?
Yes, that's an issue that we are working through internally. It's something that was of concern to us. So dental is the one area where managed care is not a big player. Only about 10% of lives are in dental managed care. So most of people accessing dental services in Medi-Cal are going to fee-for-service providers. But that is something that we also took note of and are continuing to work internally on what the best course of action is going forward.
So there's a crack in the door there with regard to dental.
We've been in ongoing conversations with the federal government, also related to dental, specifically access for children. And so there's been ongoing conversations that we continue to have. There are many different levers that can be pulled in order to improve access, rates being one of them. They are not necessarily a silver bullet, however. So there's a lot of other practices and ways to encourage more access, especially with the children. So we're still working through that.
The audit attended to those other factors as well?
The federal
Beyond
government's
rates?
concerns.
The result of the state auditor?
Adam Dorsey, Department of Finance. I believe the BSA audit was mainly focused on the rates.
Okay. And Mr. Su, do you have some compromise idea here?
Thank you, Mr. Chair. Yes, we've consistently recommended that where possible, Medi-Cal rate policy should be based on objective and reliable measures about the adequacy of rates for ensuring beneficiary access. And in light of the growing evidence about poor dental access in Medi-Cal, such as the dental audit that you mentioned, we think it does make sense to prioritize both your concerns and your resources in the budget for addressing access issues in restoring rates in Denti-Cal. This is especially because, as Ms. Balzer mentioned, most services are delivered under managed care, but Denti-Cal, in contrast, is still mainly a fee-for-service benefit that's directly impacted by rate policy. And we also think that to remain engaged on this issue of Denti-Cal access, which we think is a really important one, and that won't necessarily be solved by a 10% restoration alone, you may wish to consider requiring the administration to report to you each year at budget hearings with the findings from its annual rate reviews on Denti-Cal. The Department of Healthcare Services is supposed to actually perform these reviews annually under current law, but the auditor found that the department complied with the reviews just twice since the 2001 fiscal year.
Finance, do you have any comment on that?
Yeah, this was something that during healthcare reform implementation, there was a lot of activities on the Department of Healthcare Services plate, and so this is something that did not happen, but it is something that we're committed to making sure happens going forward.
Sue, you said it's required twice a year?
Excuse me, Mr. Chair. What I meant to say is that it's required annually, but they only conducted this review, which is statutorily required twice in the past 10 or 15-year period.
And when is it required annually? Is there a date to it? At the end of the year?
Not that I know of. It's only set in statute that they're supposed to do it every year.
Okay. Ms. Bosler, do we know, I know you're committed to it, when we will see the next report?
Yeah, so I can't give a date, but there were new requirements placed last year to make sure that we were reporting on fee-for-service and managed care, and we're committed to making sure that we're doing that going forward.
Okay. So clearly a differentiation between 10% of managed care beneficiaries for dental, 80% for managed care for broader care, big difference there. Another reason why the Senate took its action. But again, we'll be keeping this open now. Any other comments? Yes, Assemblyman Bloom.
So I understood the question from the chair to be that there may be a compromise proposal. And is the compromise that's being suggested that the administration, or the department rather, be required to provide a report that they're already required to give? That's what it sounds like. I don't mean that as a criticism. I'm just trying to understand it.
Certainly, Mr. Bloom, yes. It is essentially to require them, to actually hold them accountable to this rate review, which current law requires them to perform, but according to the audit, they haven't been doing.
So how are we holding them accountable?
If they were to report to you at budget hearings with the actual results from these reports, because the reports are not just to sort of give a lay of the land of what the rates are, but to also document how they ensure or do not ensure adequate access in the program.
But we could already, within our process, create that expectation by just demanding that they bring that report when they report to us on an, they're already coming in and reporting to us. So I'm just not sure how that changes things.
And I did just get some additional information. So we will be getting that report to the legislature by July 1st.
By July 1st. So noted. Thank you.
I think Mr. Nielsen, then I'll have something to say. Yes?
Senator Nielsen, go right ahead.
Well, Mr. Chairman, I don't know that that goes far enough. Now, this not getting reports back to the legislature is endemic and historic. Almost all agencies fail to do that. But some are a little bit more important, and this is important. And just demanding that they do means absolutely nothing to them. Now, I'm really not being trite about this. I'm wondering about a 0.5% or 1% cut in their administrative budget, unless that report is produced, or some other enforcement mechanism than our demand, which they summarily and regularly ignore. And also to the general issue, a lot of things are indeed important, but as we proceed, understanding that, all is not well, it's better. And I'm not personally willing to accept that we're out of the recession. Our employment figures show that very clearly, particularly when you take into account how many have not even, they've just opted out, they've given up. So we do have to be careful, and that means as we go through here, we surely should have some priorities, but there means some things are going to get less and just won't get funded either. We do have to be careful. That's all I suggest. Thank you, Mr. Chairman.
Thank you, Senator Nielsen.
Right, I was just going to simply say that, one of the, and I think we agree, looking at the two proposals that have come forward from the Assembly and the Senate, that Medi-Cal rates are important, obviously, for all of us. And for the Assembly, it includes dental, but it goes far beyond that as well. That one of the things we've consistently had complaints from in the medical profession is the low rates in Medi-Cal, and the fact that it doesn't do any good to have a card, an ACA card, if you don't have a doctor you can access in your communities. Many of our physicians are not taking any additional persons, not only just Western Dental, but doctors themselves, because they can't make it pencil out in the end in terms of the cost that's there. We have one of the lowest rates for Medi-Cal in the nation, and and as being one of the richest states. And so it's the one thing I've heard consistently since I've been up here is what we did with the 10% cut. And we've often looked at it and bemoaned it and felt we couldn't deal with it. So we've come up with a plan that we think is agreeable, reasonable in terms of phasing it in, the 10% across the board. That seems to be what folks want rather than targeting only certain services. We're willing to look at it, but I think based on both of our proposals that's come forward, it's obviously an item that we want to address from both houses this time around. And I would encourage those of us here to look at it, and we'll find some compromise, but it surely is something that has come to the level of concern in both houses.
Great, and now it's my turn to say it wasn't for lack of interest in restoring across the board the 10%, but for prioritization, given the difference between the 10% and dental, 80% in general. And though the numbers don't quite reflect it in the budget year, I think that, and Mr. Sue, if you have any numbers at your fingertips, the out-year differences are where the numbers are significant.
Yes, the out-year estimate for fully restoring the rate freeze and the rate reductions would be on the order of $200 million annually, based off of current estimates of utilization.
What was the number?
$200 million.
$200 million. Okay.
General fund.
Very good. All right, so a lot more to discuss on that. Page 6 deals with dental anesthesia rates. Again, Senate has a proposal. Mr. Sue, if you could share that with us.
Certainly. Senate increased the dental anesthesia rate to provide rate parity between general anesthesia and dental anesthesia providers for an estimated cost of $4.3 million general fund.
And this impacts most specifically individuals with developmental disabilities. Is that accurate?
Yes, according to our understanding, a large subset of the clients who are affected by those supporting this proposal are in regional centers.
Right. Okay. I suspect we'll be leaving that open for now.
Right, I think we support it in concept, like many of the pieces, there are a lot of dental pieces that we're looking at, so yes. Okay.
Page 7 is drug Medi-Cal, residential treatment services. Ms. Bosler.
Sure, this is where we had provided both administrative support and also funding to implement the drug Medi-Cal waiver, our new drug Medi-Cal organized delivery system that will be run by the counties. And the Senate reduced that by $5 million, given the uncertainty. I will recognize that the waiver is still pending with the federal government, but we are hopeful that in the next coming days, hopefully at the far end, coming weeks, we will get word from the federal government and we'll be able to move forward expeditiously to implement the drug Medi-Cal waiver. This is something that has been a long time in coming. It was part of implementation of healthcare reform. A big change was to include a much more expanded system of delivery for those people that have substance use disorders. We understand the Senate's position. I think our concern is that once the waiver comes in, we do want to hit their ground running. We want the counties that are very eager to get these programs moving. We want them to also be ready to go. So we do not support the reduction that the Senate took and would support the Assembly position.
Very good. The reason we took our action, not that we don't want to hit the ground running, and I'm happy to get the LAO's take on this, but that there are going to be a number of steps that have to be taken between our getting the approval of the waiver amendment. Counties have to submit their implementation plans. Department of Healthcare Services hasn't yet developed their American Society of Addiction Medicine designation program, and residential treatment providers do not yet have the designation. So, Ms. DG, could all this get done as quickly as the administration thinks it can, or do you think there's some savings, recognizing that it may not be until November or December that counties can actually implement this?
We also find, as you stated, Mr. Chair, that it's likely to take longer than assumed by the administration for counties to be able to begin providing these residential treatment services. As you stated, counties need to submit an implementation plan for approval by the department, and they need to have their residential providers certified. And as such, we find that it's reasonable to reduce the amount by $5 million general fund.
Very good. Ms. Bosler, once we get the authorization, how long would it take for DHCS to develop this ASAM designation program, for example?
Teresa Calvert, Department of Finance. I don't have a specific time frame, but I know they're working on all of the components needed to have this program implemented. They have significant county interest. I know they're talking to the Phase 1 Bay Area counties now currently to get this up and running, and so they are working on all of those components already. I don't have the specific time frame for the ASAM criteria in place, though. I can check with DHCS and get back to the committee.
And the governor's proposal is based upon a start date of September?
Yes, it builds in a cost lag. It assumes services effective July 1st, 2015 was the federal approval of the waiver, and they have kind of a 3-month cost lag. It also assumes 22 counties end up participating in 15-16 fiscal year, but it doesn't assume all 22 at once. Again, DHCS has a phased-in implementation approach where they have Bay Area counties followed by Southern area counties, and so that's their estimate of how many counties would be in place in 15-16. And that's of 53 counties in total that are interested in this.
And when are we expecting to hear finally from CMS?
We had hoped to hear by now. So I know that they're in frequent conversations with CMS and responding to CMS questions. They do, expect approval soon. We had hoped it would be in place by now, but it is, hopefully within days, weeks, not months.
So if it were a few weeks to a month as opposed to days, would you then come to the realization that probably your timeline is not going to be met? The reason I ask, meaning we should know very soon whether the LAO or your proposal is more likely.
Right. I think if we don't have federal approval near the start of the fiscal year, then we would, on the natural, when we come back and revise our 15-16 estimate, we would have had to lower the estimated costs.
Okay.
We're prepared to close out on this matter with the Senate recommendation.
We do. Okay, I'll take that as a motion by.
Yeah, we're prepared to close this item out with the Senate recommendation, so I move the Senate proposal.
With the savings of the $5 million.
Yes.
All right. That would be 3-0? 3-0 on the Senate side
Everybody's here. Yeah, we're all good.
and 3-0 on the Assembly side.
Good.
We've closed a page.
Can't believe it.
All right.
Tear it out.
We're on a roll.